Hello, I'm Michelle Levander, Director of the USC Center for Health Journalism. Thanks for joining us today, and welcome to our Health Matters webinar covering coronavirus, the long road to recovery. The medical establishment is just coming to grips with a patient experience with COVID-19 that defies expectations and our understanding of the course of the disease, that those who became sick fell into two camps, those who became severely ill and those who had only a mild collection of respiratory symptoms and fever. Today, we'll be learning more about a third group who are experiencing an array of COVID-19 related conditions that endure for weeks or even months. The wide range of enduring problems that these patients experience is perplexing to researchers and clinicians. It includes everything from heart damage and shortness of breath to brain fog, crippling anxiety and depression, and traumatic stays in the ICU. Estimates of how many people experience these symptoms are imprecise. And we have about more than 5 million confirmed US COVID-19 cases, and we could be talking about anything from several 100,000 to many more, up to 30% of those diagnosed. This population is known informally as long haulers, a reference to the long duration of the illness. In this webinar, we'll learn more about what we know and don't know about long haulers, their challenges in the medical and insurance system, and the best ways to sensitively report on their experiences. Here to help us understand all this, we have three distinguished speakers. David Tuller, a senior fellow in the Public Health and Journalism at UC Berkeley Center for Global Public Health. He received his public health doctorate degree from UC Berkeley. He also was a reporter and editor for 10 years at the San Francisco Chronicle and served as health editor at Salon.com. He's written regularly about public health and medical issues for the New York Times, Health Affairs, and many other publications. Since 2015, he's been investigating scientific, methodological, and ethical problems with research on the illness or cluster of illnesses known as chronic fatigue syndrome. His ongoing series on this issue is called Trial by Error. And then we have Fiona Lowenstein, a writer, speaker, TV producer, and media consultant based in New York City. Fiona is the co-founder of the Body Politic COVID-19 support group, which provides emotional support and resources to thousands of patients all over the world. And she's the founder of Body Politic, a queer feminist wellness collective. Her work focuses on how health and science intersect with culture, politics, and social justice, and her writing has been published in the New York Times, Fox, The Guardian, Teen Vogue, Bustle, and the Columbia Journalism Review. Fiona also has firsthand knowledge of the topic of today's webinar. She is herself a long hauler. And she will be speaking with us about journalism, the COVID-19 patient experience, and the COVID patient advocacy movement. And we'll also hear from Dr. Heather Varich, a cardiologist and clinical researcher at the Veteran Affairs Boston Healthcare System, Brigham and Women's Hospital, and Harvard Medical School. He serves as Associate Director of the Heart Failure Program at the Boston Veterans Association, Veteran Affairs. His research focuses on end-of-life care for patients with heart disease. He's been published in journals such as the New England Journal of Medicine, Journal of the American Medical Association. He is also a writer and has authored 2 books, State of the Heart, Exploring the Health Science and Future of Cardiac Disease, and Modern Death, How Medicine Changed the End of Life. He's written for the New York Times, The Guardian, The Atlantic, the LA Times, and the Boston Globe, and has appeared on CNN, Fox, CBS, and other stations. We want to thank the National Institute for Healthcare Management Foundation and the Commonwealth Fund for supporting this program. You can be tweeting about it at the hashtag LongHaulers. A word about our format today. We'll be hearing first from our panelists, and then we'll turn it over to our audience for questions. Because we have many people participating in the webinar, we'll ask you to write your questions in the Q&A panel on Zoom. You can also write us there if you're experiencing technical problems. We'll be archiving this webinar at centerforhealthjournalism.org. And now let's get started. David, why don't you get us going here and tell us just about the emerging knowledge in medical circles and patient support groups about this group of people that are being called long haulers. They don't fit a typical pattern of what we come to understand about COVID-19. Who are they and what are they experiencing?
Okay, so I thought it would be maybe helpful at first just to sort of talk a little bit about post-viral syndromes in general. And, it's a very well-known phenomenon that after many infectious illnesses, and often specifically we're talking about post-viral illnesses, people get a bad flu. It takes a few weeks to recover. We don't really know why people have that fatigue, those muscle aches and so on that last for longer than the infection itself actually lasts. But that's a very common phenomenon that we're all familiar with. And we've seen in previous epidemics like SARS that people had long-term, there were a certain percentage of people that have had long-term chronic ailments from that. Again, some of them, and again, after H1N1, after West Nile virus, we see regularly that there's a post-viral condition that people get. And for some people, these conditions, again, it can go on for months. Usually they have a self-resolving nature. They, after a few weeks, after a month, and so on, in most cases, most people get better. So when this epidemic started, it wasn't surprising that people were sort of predicting that there would be some percentage of people who would come down with some sort of long-term symptoms. Again, hard to track because they're often very kind of non-specific symptoms, flu-like symptoms, respiratory symptoms. A lot of people after viruses often, in the past, we've seen have what seem to be neurological symptoms, brain fog and so on, and that's something that we've seen reported a lot. One of the issues that comes up a lot with these issues, and we've seen this a lot in the area of ME or chronic fatigue syndrome, which I've written about a lot, which is also known more in the UK as myalgic encephalomyelitis, which is a handful, but that's sort of what is a more specific name perhaps for what the thing that is called chronic fatigue syndrome. But basically, we see that many patients do not get believed because a lot of these symptoms are non-specific. And it's very common that clinicians are very uncomfortable when they can't say specifically this symptom is being caused by that thing. And with post-viral symptoms and post-viral syndromes, this happens all the time. The reason we're seeing this so much now is that this is a worldwide epidemic with many, many millions of people infected. So we're seeing what often might have happened on a smaller scale, but just at a mass level. And what we're also seeing is that because this virus is so protean in the way it can impact different organ systems, is that the range of symptoms that people are reporting is really quite vast. And if you go on like Fiona's sites or some of the reports that have come out of Fiona's group and others, you see that the range of symptoms people are reporting is really, really vast. And that's partly because some of them are maybe related to the virus itself. Some of them are related to impacts of the virus on immunological systems and other sort of physiological processes. Some of them are probably related to the cardiac damage we've been hearing about. Some are related to the lung scarring. So there's basically a huge range probably of what we're going to see post-COVID syndromes. And it's very difficult to research because again, we don't, a lot of the patients are doing self-organizing. But we're just at the beginning of this morass, and it's just something that's going to take quite a while to sort out in terms of who gets it, who's vulnerable, why are some people vulnerable? Is that something to do with their own physiologies? Is that something to do with the virus, where it attacked them, and so on? So there's just so many issues that will need to be worked out in ongoing research.
And David, you've been a strong advocate, really, for trying to get some tracking systems in place early and to build a database to really better understand this. Tell us a little bit more about that.
Well, I think one of the issues always in tracking a post-viral syndrome is that often people have not tracked them at the same time and in real time. It's sort of, we've had SARS, there weren't that many people infected, so you treat SARS and then 6 months later, oh my God, people are still having symptoms, but you don't necessarily have the data to understand why did some people get better and why did some people get sick. You have to do retrospective studies and so on. So the idea here is, I think, to for there to be kind of ways to sort of track in real time. People get sick, and then, when you look in the papers today, or in the papers, I'm an old person, when you look in the media today, you see the categories. We don't see a category of long haulers or people with post-COVID syndromes or anything. We see deaths, we see hospitalizations, we see infected. There's a huge, vast thing that's really not being tracked effectively. I mean, at this point, there's different projects that have started up. So it's being tracked here by that group, and in Europe by here, and this. So there are things being set up. And I think it's important. That will be the only way. If you take sort of data and samples from people as they go through COVID, and then as they either get better from it or do not get better from it, it will really help distinguish why some people are getting worse. And some of that may be very helpful for other post-COVID syndromes like ME or ME/CFS, where we don't know a lot about that because it's been so ignored, and because many people with ME have just been told, oh, go exercise, you're just deconditioned, or go get psychotherapy. You think you have this illness, but you don't really. And so we haven't actually really researched biomedically in the past. And if we had researched ME effectively, maybe we would know a little more right now about what people like Fiona are going through with post-COVID syndrome. As it is, we know almost nothing about any of this because the research hasn't been done. And this, unfortunately, gives us a great opportunity, not unfortunately, but it's unfortunate, this does give us a good opportunity to really track these continuing problems going forward as a way to document that patients are not making this up. They're not just pretending, and they're not just sort of assuming that they have these things. Or extra focusing too much on their symptoms. They actually have these disabilities, and it would be wonderful to be able to use this opportunity to track going forward prospectively rather than retrospectively why some people are getting sick, what are their characteristics, and what are the characteristics of their infection that make that happen.
And David, I know Fiona will be talking about this a little bit later, but one of the issues for some of the folks who are known as long haulers is that they may not test positive. By the time they get the test, it may be too late. And so what kinds of challenges are they facing in interacting with the healthcare system and getting covered for their treatment?
Well, okay, so let's say that everybody who's having some of these symptoms might be faced with skepticism on the part of the healthcare community, if I've heard from people, even if they have a viral test, because the symptoms are sort of so nonspecific that they're questioned as to whether it's really just post-traumatic stress disorder or anxiety and so on. So that's happening even if you have a positive viral test. Now you can imagine if you don't have and most people who have this, because we had a completely inadequate testing system and still do, and people were not being tested, and people were being advised to stay home and not come out and get tested because no one really anticipated the actual need for this documentation that you had this viral illness. Nobody was thinking, oh my God, we're going to have tens of thousands or hundreds of thousands of people with post-COVID syndrome, so that they're going to actually need documentation, otherwise they're not going to be believed. So this is a total sort of mess up on the part of the lack of a national testing plan from the beginning. So yeah, those people, to the extent that people who even have a positive viral test, and then there's the problems with the test. So you might have had a test, but again, it was more than 2 weeks after your initial infection, so it might have likely showed up negative. So people have two negative tests, say, but they were taken too late, and they're never going to have a positive viral test. And maybe they, with the antibody test, maybe they'll be able to get a positive antibody test, maybe not. That's also very squishy at this point as to what those tests mean. So it's very, very hard, and that makes research very difficult as well, because from a research perspective, you do want to make sure that someone actually had the thing. It's not the fault of the person who was not able to get the test, but unfortunately, as a researcher, you are likely to want to know 100% that this person did have this, because otherwise your data can be very complicated. So it creates a real problem, and I don't know yet about insurance companies. I am sure that we will have a lot of insurance companies. I'm sure people have had insurance problems with this. People are supposed to, in the US, weren't we supposed to be offering free healthcare treatment to people with COVID? Well, if you can't prove it, then you could say, well, you're just a hysterical woman. This is all more happening to women as well. And women are more likely to be the ones psychologized in ME and in this one as well, I would guess. So, I think it's a real challenge, both for clinicians and for researchers, on how to deal with that. And I don't really think there are great answers, except to say, we should have had a much better testing system so we wouldn't be in this situation at the moment.
And, David, you talked about the challenges for researchers and clinicians, but I imagine there's also challenges for journalists, because we too are following the lead of our sources. And even though this is a relatively new illness, we've been, we see it in a certain framework, in a certain box. So, both now, are we kind of undercovering this now? And I also wonder, from thinking back on other diseases like Ebola, where there was really very little coverage after the kind of most scary stages of this passed, of the, the lingering effects for people who had suffered, and are we going to just sort of as a herd, tromp off and neglect this condition, which could be in a way the ongoing story of the pandemic?
So I think this condition, this continuing condition, will be one of the big stories going forward, and I think it will be impossible to ignore. And I think, again, I think the journalism world has been horrible in the way it's covered ME and chronic fatigue syndrome, and the way it's basically taken the prevailing view until really the last couple of years, or the prevailing medical view that this is just a psychiatric, or this is just a thing of people who sort of imagine or deconditioned and need, treatment for their to exercise and get back to work and so on, or cognitive behavior therapy, which has been especially prescribed in the UK. So I think there's this whole template of people with these non-specific post-viral conditions that's taken hold, among journalists too, because they listen to the medical community. And so this has been, in the US, it's been a very strong tradition that we don't really take these post-viral things very seriously, because we consider them kind of psychiatric manifestations of some sort of hysterical women, often, for the most part. And so I think what's happened now is that it's impossible to deny that there were many people out there who were suffering. And I think, again, the previous failure of journalists on the part of ME is because, they might value expertise over the testimony of patients for understandable reasons. Journalists are not clinicians. If we read something in journals, we think it's true. Although we see now that journals have their own problems of bias and so on. So I think one of the things that is happening here is that I see journalists taking it extremely seriously, partly because many of them know somebody or they've had it themselves. And so I think the attitude towards this hopefully will also reflect backwards on people will think, well, maybe that person I know who said they had chronic fatigue syndrome and has been sick for 15 years, maybe they really weren't making it up, and maybe they really were sick. And maybe the doctors and people who said they were just kind of having psychiatric problems or delusional are not right. Because I think, it's impossible to dismiss the many, many people who are coming up with, who are reporting these things. Now, anytime you don't have a biomarker, there are going to be some people who don't have the illness. Obviously, some people who now say they have post-COVID had a bad flu, and they didn't have COVID, or they didn't have a coronavirus infection. It's going to be very, very hard to sort that out. Hopefully, we'll have better tests going forward that will be able to determine on a more long-term basis, in the future, who actually had coronavirus infection and who is suffering from something else. It's hard to distinguish those people at this point.
Yeah, and I'm going to turn now to Fiona. Thank you so much, David. And Fiona, you're in a funny position because you're wearing two hats these days. You're a journalist, but also a patient and a long hauler. So I'm wondering, what are the central insights you've gained from this hard-won experience about what it's like to be a long hauler and the challenges that people experience who are going through this with their doctors, their insurance companies, and their friends?
Yeah, that's a great question, Michelle. I became sick on March 13th, and I remained symptomatic until early June. So, I was a long haul patient for several months, and it was during that time that I started the Body Politic COVID-19 support group, and connected with thousands of patients all over the world. And in that process, in those early months of March and April, I was sick myself, but I was also seeing what others were experiencing. Of course, I was reading the news constantly and looking for stories that, mirrored my experience. I was young when I was hospitalized for COVID. I'm 26 years old. I had no pre-existing conditions. And I assumed that after I was discharged from the hospital that I would recover quickly. And that was not the case as for, many others. So in those early months, there was really a lack of information about this, variety of symptoms. We didn't understand that COVID could affect almost every system of the body. And at that time, I was hearing these anecdotes in our support group and kind of realizing that the mainstream media narrative of COVID was neglecting some of the nuances of what is actually a very diverse patient experience. And even when we talk about long haulers, we are talking about, anyone who has had COVID-19 symptoms for more than a month is generally kind of the definition I've seen used. So that includes a lot of people, right? That includes people like me who were sick for, 2 to 3 months and recovered. It includes people who have any sort of mild, condition after a month. It also includes those who are still sick, 5 or 6 months down the line and may end up being diagnosed with some sort of, chronic condition like myalgic encephalomyelitis, chronic fatigue syndrome, or, another disability. So I think that's important to note as well. Very early on, I started writing about some of the issues that I saw coming up in the patient support group that I didn't see being addressed by sort of the mainstream media. So I wrote, what I think may be the first reported piece on long haul patients in the New York Times on April 13th, which was really just kind of talking to all of these people who had been sick at that point for exactly a month, but didn't seem to be getting better. And then from there, I started to notice that there were a variety of other, not just long-term physical impacts, but long-term social, emotional, and financial impacts. So, we talk a lot about kind of the high cost of healthcare in this country. And certainly, my hospital bill was almost $14,000 for 2 nights. It was luckily covered by my insurance mostly. But there's also, a lot of other kind of hidden costs that emerge when it becomes clear that, you're not really able to take care of yourself. So, in some cases, that means that just thinking of one patient I'm in touch with, she can't cook herself food because her neurological symptoms are so intense that it makes it very difficult to kind of concentrate on one task at a time. And she realized very early on, I'm going to set my house on fire if I keep trying to do this. So, there's the added cost of having someone make you food or having to order in food. I mean, that's just something very small, but I think it's not often talked about. And then of course, there's, the issues with employment. Disability benefits in this country are not what they should be. And many COVID-19 patients are, not eligible for them at this point. And many employers are skeptical of long haul patients who say that they need additional time off because there was this pervasive myth that recovery should only take about 2 to 4 weeks. So I think that, this is where journalism plays an important role, because I have heard from patients who have shared stories that, I and others, like David, have written with their employers, news articles kind of talking about this phenomenon, and have said it was the article that made my employer, realize that they needed to give me additional time off. So I think raising that awareness and kind of creating that visibility is in many ways the first step to helping these folks, achieve some of what are now, I guess, beginning to be advocacy goals of this emerging patient advocacy movement. But yeah, I mean, there's mental health effects as well. Obviously, there's kind of the trauma of dealing with this for months at a time. And then, there's social isolation in addition to the physical isolation, because, many of your friends can't understand what you're going through. When we were all in quarantine, patients are not able to call into Zoom happy hours or go on a run to lift their mood or any of kind of the mental health suggestions that the rest of us were receiving. So it's a virus that can impact every system of the body. And I think for long haulers, it ends up impacting kind of every aspect of life. And the last thing I'll say about that is that, this is nothing, of course, this is new in the sense that this is a novel virus, but this is nothing new in the sense that people with chronic illness and disability have been talking about these issues for years. We just have not been listening in the way that we need to. And, I include myself in that group because prior to contracting COVID, I wasn't aware of really what myalgic encephalomyelitis, chronic fatigue syndrome even was, let alone the common misconceptions around it and other chronic conditions. And I think it's important to note that while these long haulers their experience may diverge from kind of what we understand to be the classic COVID experience, it's not super surprising or unusual to see people with viral infections develop a variety of sequelae. We've seen that in past pandemics. We've seen that in past disease outbreaks. The reason that we're not as aware of it is because those people typically just get left behind and forgotten. So I think that's what we're all hoping, will not happen this time around.
Thank you so much, Fiona, for sharing that. Based on your kind of insider, outsider perspective on this, what advice do you have for journalists on how to sensitively connect with and report on long haulers? How can people find them? Do we need to be thoughtful about how we approach people in online forums or even, Twitter or Facebook? And also when we write about long haulers, what should we be thinking about in terms of the vocabulary that we use?
Yeah, so I've been on both ends of this. I've been a patient who's been interviewed, at my sickest, and I've also been, a journalist kind of covering these issues and interacting with patients. So I've certainly learned a lot along the way. I think, one of the common kind of misconceptions is I think a lot of journalists don't understand that many of these patients are often dealing with very intense fatigue. And, as people in the, myalgic encephalomyelitis community will tell you, pacing is really key to being able to kind of, I'm not going to say go about your life as usual, but be able to, accomplish kind of anything in your day and not worsen your condition. So by pacing, what we're referring to there is kind of, the idea that you're spacing out activities, that you're allowing lots of time for rest. And so many COVID patients, are very carefully planning the interviews that they do with reporters. And I don't think that as reporters, we're always that aware of that. We're often working on tight deadlines. Sometimes we're working in newsrooms where the story is constantly changing and, we're finding out, oh, we have to do this at the last minute. But a lot of times, a patient has actually crafted their entire day around this interview to make sure they have time to, rest before and after. So I think it's really key to, try and respect those patients' boundaries around time, especially when it comes to these interviews. And also keep in mind that not every patient is going to be able to do a telephone interview or an on-air interview. So some patients, there's a patient I was in touch with recently who is still extremely hoarse from being sick and really can't speak. So she has to conduct all interviews via text and email. And, that's not every reporter's favorite way of doing things. But I think being clear also about the scope of your project, how long the interview will take, what sorts of questions or topics might come up. It's going to be helpful since a lot of these folks are dealing with brain fog as well. On a broader level, I think there also still needs to be more diversity in terms of which patients we're talking about and which patient experiences we're featuring. And a lot of this comes down to, whether or not to interview patients who have not tested positive for COVID. So, my feeling is that it's really important to talk to patients with a variety of test results, those who tested positive, those who tested negative on their PCR test, those whose test results were inconclusive, and those who weren't able to get tested at all. We know that the PCR tests have at minimum a 20% false negative rate, and that's kind of if you're tested at the exact right time. The phenomenon with a lot of long haulers is, if you're in New York City right now and you're a long haul patient and you've been sick for 5 or 6 months, that means you probably got sick in March or April when testing was really hard to access. And, I can tell you that I am the person who infected me was never able to get tested. My partner was never able to get tested. The only reason that I was able to get tested was that my case was severe enough that I was hospitalized. And I also sought care at the right point in time that the hospital was able to accommodate me. If I had gone to the hospital even a week later, I don't know that I would have been admitted, because as we know, a lot of healthcare systems have become incredibly overwhelmed as a result of this pandemic, and the standard for receiving care is changing kind of day to day. So that's very important to keep in mind, because, I always say that COVID testing is really a social justice issue, because a lot of the people who are not able to test positive, are often people from, already marginalized backgrounds, whether that's because they lack health insurance or, they have perhaps preconceived notions of the medical establishment and very, very reasonable fears about the medical establishment based on, past experiences. These are important things to keep in mind, because when we limit the scope to just those patients who have tested positive, we're very likely to leave out long haul patients. And we're also very likely to leave out patients who may have experienced medical bias or medical gaslighting. So, David spoke a lot about kind of the prevalence of long haul COVID and other chronic illnesses amongst women. And I can say that, I don't know what the gender breakdown is, but our group does seem to skew heavily toward women. And we also know that Black and Latinx populations are most likely to go undiagnosed for myalgic encephalomyelitis. So when we think about kind of which communities have been intensely impacted by COVID and the ways that medical bias and medical racism plays out, and the question of whether or not, these patients are actually going to be able to receive the proper diagnoses for potential, disabilities or long-term conditions that may come from this, we also have to be thinking about identity and politics and kind of the ways that these systems work.
So it sounds like you might think it would be worth the effort to try and find those voices from, say, Latino or African American communities, because they, just by the sheer numbers of people who are getting COVID, while they might be underrepresented in our stories, they're overrepresented potentially in this long hauler category.
Absolutely. I mean, I think it's ridiculous that the majority of the times that I've been interviewed about my patient experience, it's alongside other white patients. This disease is disproportionately impacting communities of color, and we need to be telling those stories in more than just headlines with, kind of the statistical information. Also, again, medical bias is not new, medical gaslighting is not new. The experience of being, kind of turned away from care or not having your pain taken seriously is something that, many, many women, LGBTQ plus folks, people of color, people with disabilities and chronic illness, people with past histories of mental illness have experienced. So we also need to be talking to those folks because they have the insights on kind of what this feels like and often have long histories of experiencing this. I wrote about a patient in a piece I wrote for Vox who, said this is not new to me because, I had endometriosis for years, but it went undiagnosed because I'm overweight. And I was told that, my issues were just due to my weight and no one would, kind of do the necessary examination. So I think that's really key to keep in mind. And yeah, I mean, I would really urge anyone reporting on this topic to dig a little bit deeper beyond kind of those patient stories that have already been told and question whether the stories that you're choosing to include are perhaps, being chosen because they kind of fit this already whitewashed narrative that we're looking at. And I think support groups are a great way to find patients. It's also, there are a lot of patients talking online in open forums on Twitter, on Reddit. Just searching on Twitter for long haul COVID can connect you to a lot of people. And I think when reporters are reaching out to support groups, the most important thing to keep in mind is just making sure that if there are any norms or guidelines that the support group administrators are, sharing, that you're making sure to read those and kind of making sure that you are interacting with the group in the ways that the group wants to be interacted with. Because some patients find it incredibly cathartic to tell their stories. Others really do not want to be, bothered by reporters.
Thank you, Fiona. And just want to mention that since Fiona runs this very well-known online support group, she's a potential pathway to you to finding some voices. And I also want to mention that we did an earlier webinar in this covering coronavirus series called Street Reporting Without the Street that offers a lot of tips for how to reach hard to reach communities. And so that's another potential resource for you. So
I just emphasize very quickly or back up what Fiona was saying about, because I've come across this a lot with the ME community, that you do want to get them back to, get them back, they should get back to you right away, or you have to you're on a deadline, but people really are operating under a different kind of strain and stress. And so there really are maybe they can't use their computer because there's too much light sensitivity. You really have to, or don't, I had to go to interview people and I'd have to wear a dark shirt because if it has lines or spots on it, it's, there's a hypersensitivity to stimuli that many get. So you really do need to listen to the patients about what are their conditions or what will make them feel most comfortable and able, and not have to, not many do pace and they don't want to have a crash afterwards. So that is an important point. Sorry.
Thank you, David. And we're going to turn now to Dr. Varich, but I did just want to mention for those of you when we get to the Q&A section that Fiona and her organization have done a survey of the patients in Body Politic COVID-19 support group. So if we have time, we'll have her talk a little bit about that. But let's turn to Dr. Varich and have you explain a little bit to us some of this emerging data about some of the ways that coronavirus is spreading to other body systems and organs, particularly the heart, which is your area of expertise. And what do we know about that? And how well is that knowledge reaching clinicians in this country?
Thank you, Michelle, for inviting me. And it's actually just enjoyed just listening to some of the other panelists talk from so many different perspectives as a journalist, and then Fiona, both as a patient and as someone who's covering this important topic. So, I think, many months into this pandemic, we know so much more about COVID-19. It really, if you look at the, what does SARS stand for? SARS stands for Severe Acute Respiratory Syndrome. And just by that and the reason it was named such was because it's related to, SARS-CoV-1. I think what we're now realizing is that COVID-19 is far from a respiratory syndrome only, even though that can be, it's some of its more common and more sort of dramatic presentations. In fact, I recently wrote a piece, and Tom Frieden, who former director of the CDC, in fact suggested that maybe we should just rename the condition into something like, an acute inflammatory disorder, which might in fact be more representative of what we've seen so far. So, since this virus was first discovered in Wuhan, we know a lot more about it. And one of the things that we know a lot about it, and has been mentioned before, is just how widespread and diverse the manifestations of this condition can be. And for me, this really sort of hit home. I've had a recent patient who essentially developed heart failure from COVID-19, and his story was, I think, telling, but also kind of scary, because this man, he was about 40, 50 years old, middle aged, had really never been sick before, got in what sounded like a pretty bad COVID infection, and essentially never sought medical care, stayed at home, kind of hunkered down. And by the time he got out to his primary care physician, he tested positive, and then he got better, kind of started his life again, and then he started to get sick again. And what happened was that he discovered that his legs were swelling, they're full of fluid, and this was essentially more than a month after he had his initial presentation. And then by the time he came back to the hospital, he was actually way sicker than he was before. We found that his heart function had been really severely affected, and in fact is now being worked up to see if he might need a heart transplant. Uh, and this is really a very dramatic, again, a very, very dramatic example of just how far and wide the impact of COVID-19 can be beyond just the lungs. And recently, we've learned a lot more about this condition of inflammation in the heart, which is called myocarditis. It's become really a point of contention as far as even the resumption of college sports is concerned, because we now know that many college athletes, and in fact professional athletes, in fact the starting pitcher for the Boston Red Sox, have been found to have myocarditis. And the reason why we're seeing myocarditis in these athletes is very simple. These are the people who have access to the greatest resources. My sense is that if everyone with COVID-19 was getting cardiac MRIs, and not that everyone needs one, we would see that this condition would be, in fact, more common. What's made this really challenging is, in fact, been the research response to this phenomenon of long haulers. So we've all talked about how broken our healthcare system is, but I think what COVID-19 is revealing is that our healthcare infrastructure is also probably as broken and redundant as our healthcare system. So the United States has, in fact, lagged behind other countries and is in generating knowledge about patients with COVID-19. In fact, we've not had any major sort of breakthrough trials published from the United States, and my worry is that we will also do the same with regards to the long-term follow-up that many of these patients need, that I think David has already mentioned. And part of it is, historically, we've not paid attention to post-viral syndrome, so we don't really have a way of knowing, well, what is the normal, so what is the long-term outcome of someone, say, after they have influenza, for example, or another type of viral illness. So we have no way to sort of compare how patients with COVID-19 are doing with what you would expect with any other type of viral organism. And my worry is that the sort of lack of national leadership that we've seen with regards to our pandemic response, we're also seeing that in our research response as well, is that we are really missing an opportunity to really understand this disease, not only its acute phase, but also thinking about the long-term impact of this disease on patients. Which will, and so even though there's been, and I think that the work done by people like Fiona and reporters has been really commendable, in the end, the real insights about this condition have to come from robustly designed prospective studies, as David has mentioned, and that to me is just going to need a lot of collaboration between academics and scientists, which unfortunately we just haven't seen. With regards to understanding why COVID is having, or SARS-CoV-2 is having such a dramatic impact on other organs, we still don't know if, for example, with regards to the heart, the question really is it the virus having direct impact on the heart? So really what we would call myocardial injury from direct virus infecting the heart, or is it just a reaction to the inflammation that the viral infection produces, and that inflammation is the one that's really directing that's essentially misfiring and affecting other organs like the heart, the thyroid, and other such organs. So, I think that we know a lot more about this condition than we did a few months ago, and I think that there have been some really commendable advances. But I think as far as this long haul syndrome is concerned, I think that we're still lagging behind. And I'm not sure if that knowledge is going to unfortunately come from the US. I think we might end up looking to other countries such as Europe and the UK for some of those insights, which is unfortunate.
And what do you touched on this already, but what else do we not know about this? What other questions do you think need to be answered?
So I think one of the things that we don't understand is how does the initial infection impact your overall course? Like I think most people would normally assume that if you have a severe infection early, then you're more likely to have a severe severe complications down the road. But one of the things that we're seeing is that a lot of, at least in some of the studies that have looked at this, that many patients who were developing late manifestations of this illness did not in fact have a serious infection to begin with. So there's this one study, and again, this goes to some of the challenges of covering COVID as a communicator. So one of the studies that looks at this in a better way than really any other was a study performed in Germany. This was published in JAMA Cardiology, and it was a study of about 100 patients who had developed and supposedly had gotten clinically better from their initial infection. And they looked at them about 2 months after their initial infection, did essentially an MRI, which is an advanced imaging technique to look at the heart in detail, and found that inflammation was very common in these patients. Now, that study was, in fact, formed an important part of my op-ed in the New York Times, in which I focused on some of the cardiac effects of COVID-19. But even since I wrote this essay about 2 weeks ago, that original paper has actually undergone a massive correction because there's actually many errors in the paper. And so it says a couple of things. One, it says is that right now there's such a rush to produce research regards to COVID-19 that we have seen some major setbacks, and that studies like this, even though they, I think, are addressing an important question, if they're not done well, they actually erode trust in the entire scientific enterprise to begin with. So I think as someone, even when I was writing my op-ed, I was careful to not base my entire argument based on that one very compelling study. But I think it does, I think when we don't do these studies well and they either get retracted or they get corrected, I think, a lot of people will have legitimate questions about what this means. And the other thing that we don't know, it goes to David's point about the fact that we don't really have a control arm, which is essentially that what is the impact of, say, sort of common cold or influenza in patients who get these infections and apparently recover. So we don't really have a great way of knowing how the patients who are getting COVID-19 and having these long-term symptoms, how they compare with other patients who may have had similar syndromes from other viruses. So my hope is that we will do better, and that I think now the people will start focusing more on designing the well-performed studies that are needed. But I'm skeptical as far as at least the national leadership in the United States is concerned.
And you pointed out that when you were writing about this, you had been careful in how you phrased all this, and we're in an environment right now where even the normal and sometimes flawed process of medical peer review of research is a bit undermined. We're seeing a lot of things published as preprints, they're called, and we're also seeing some researchers make some sometimes somewhat irresponsible pronouncements that then become sort of viral news because journalists' impulse is to chase, the newest, most exciting thing. And so what would be your advice to reporters on just like some simple steps they could take so they don't sort of trip over themselves in their rush to get, the newest research insight into their outlet?
Great question. And I and I do agree that, right now there is such an appetite for more knowledge and more insights into this virus, and some of it, and it obviously makes sense that we have this terrible infection that's, ravaging the entire planet, and we want to do our best to be ahead of it as much as we can. But it is creating a challenge. I think a couple of sort of simple tips, and I think others have highlighted this as well. But always interview more than just the primary researchers. Always seek out other folks or researchers in the field who might be able to offer a different perspective, who may not be affiliated with the group that wrote the paper. I think one of the things that we're seeing is that, and this is again, this is the first disease, this is the first really, really major disease that's come out in the social media era. And part of what we're seeing is that some of the best critiques of the research are actually also on that medium. So in fact, this paper in JAMA Cardiology, some of the best critique, in fact, the critique that led to its correction emerged from Twitter. There's a researcher in the UK, Darrell Francis, who is really one of the smartest people in our field, and who noticed some just very basic errors in the table and then just put them out there. And I think that really started this whole process going. So in fact, some of the studies that were retracted from the Lancet and the New England Journal earlier on were also things that started with people just paying attention to these studies on social media. So if you have a study that you're interested in, maybe go online and see if there's been, what are other researchers saying about it in their sort of own sort of small niche circles, and see if you can glean any insights from that. I think that is an approach that is useful. The other thing is that the more studies you can use about a specific area, the better. And anytime we rely on any one study to come to a conclusion, we will always just be, focused on one specific part. So again, that can be hard when you have a novel infection, where we just don't have a lot of diversity of work. But I think that's another sort of thing that I would advise. And so I think the more sources you can have, both as far as people, informants, and sort of studies, I think the more well-rounded you can be. And always look at the limitations. So for this, I've specifically wrote that the generalizability of this study is limited, and that the implications of finding this sort of condition on the heart, about what it means, is also unclear. So I think just being upfront about that means that even if there is a correction afterwards, you still feel like, well, you did the best job in making sure that you were not just parroting talking points, but that you're being as balanced and measured as possible.
Thank you. We're going to turn in a moment to questions from the audience, but I did want to just offer a tip on a good way to follow up on Dr. Varich's suggestion, which is there's a database of every study called PubMed. And if you look it up and you find a study, you can also see the names of other related studies and click on that information and get emails or affiliations for those researchers. So it's a really quick, easy way to find out who else is in that field.
Can I make one other suggestion, Michelle?
Yeah.
So when you look at the introduction of any study, if it's a decently written study, it should actually give you a sort of a summary of the state of play in whatever it is it's looking at. And that introduction, after a couple of paragraphs, should also outline X study found this, Y study found that. We're doing our study because this is the first time we want to find out if X, Y, Z. So the introduction should lay out for you exactly what the research question is, what they're looking at, what the previous counter studies have shown. And so just from the introduction, you should be able to get, again, if it's a decent study, what the other studies are that have shown, and who some of the disputants if it's a disputed issue, who some of the people taking the opposite point of view. And many journals now have rapid responses, so you can often see within a day or two 10 different comments of people disputing or people arguing about it and so on already. So there's a lot of people online, as the doctor says, already commenting that you shouldn't have to be going blind, just repeating what a study says.
Thank you, David. And I do want to, and I don't know if all of you can maybe stay a little longer just to make sure we have time for the questions. And if not, maybe just send me a quick message through the chat. But I did want to ask Dr. Varch one other thing, which is about your research using CDC data about how delaying care might lead to higher rates of death from heart disease. And this seems particularly important in the context of what Fiona was talking about especially communities of color and not being taken seriously, that they might be the folks perhaps most likely to get delayed care. So maybe just very quickly so that we can then turn to our questions, let us know what you found.
Sure. So, I mean, this is just as part of the op-ed, I looked up the CDC database about excess deaths from different causes over sort of a baseline period. And, you know, I know the CDC has received a lot of flack, but they do maintain kind of this running dashboard. And that breaks down excess deaths in this year by week, actually, compared to previous years. And so one of the things that I noticed there was that many tens of thousands of more people have died of heart disease this year compared to last year, the average of the last 5 years. Now, some of that is likely because of patients had serious COVID illness and they died of a cardiac cause. They perhaps never got tested or the test wasn't positive, but a lot of it is also because, especially when the pandemic is out of control and hospitals are being overwhelmed, that people are just afraid to leave their homes even when they have very serious symptoms such as chest pain or if they have stroke symptoms. So and I think I think some people have taken this data the wrong way and have said that maybe we're overdoing the measures to control the pandemic, but really I think it makes an even stronger case that unless you get the pandemic under control, that not only are you going to have a sort of large number of people getting infected directly from the virus, but people are going to be afraid to just come to the hospital for routine care because they're going to see that the hospitals are overwhelmed. They're going to feel like they're putting their lives at risk by just leaving the home. So really, that's another reason why we need to be really focused on controlling the pandemic, not just because we want to prevent people from getting infected, but we also don't want to prevent people from coming to the hospital for other non-COVID related causes. And I've seen that certainly in my practice as well, although that has gotten better. But the patients who were coming to the hospital when the pandemic was really at its peak in Massachusetts were patients who were really, really, really sick. And a lot of patients who probably should have come and sought care were not, because they're just so afraid that they would just not they would just not be safe in the hospital. And the way to allay those fears is, in fact, by controlling the pandemic.
Thank you. So we're going to turn now to our audience, and there's the Q&A panel. We already have about 16 questions. I don't think we're going to have time for all of them, but let's try and go through a few of them. I wanted to start with one that really touches on this idea of, well, what is a long hauler? Because it's such a kind of confusing array of symptoms. This is from Mahedi Shanawaz, who says, well, as Fiona is speaking, if someone contracted this disease and back in March or April, but doesn't show or mildly shows symptoms until now, should we automatically assume the person is a long hauler? And how should we describe that person?
So I'll say that the definition of long hauler that I've seen circulating in our support group is anyone who is sick with symptoms for more than a month, and that includes those who experience, feeling better for some period of time, and then as the term that's often used in the group is relapse into old symptoms. And I think the reason that we talk about that is because it does seem to be a very kind of classic situation for these long haul patients to experience days, weeks, occasionally even a month of feeling significant improvement in symptoms and then relapsing into old symptoms. These relapses are sometimes triggered by physical or mental exertion. They sometimes don't have any clear trigger. We are also noticing that, a lot of patients who have menstrual cycles are experiencing worsened symptoms or relapses of symptoms during their menstrual period. So the question of kind of what do we call these people? Are they long haulers? Are they not? Again, I think the definition is quite broad at this point. I think it is anyone who kind of has symptoms for more than a month. It unfortunately the conversation gets even more complicated because there are similarly questions about reinfection, right? Can people get COVID for a second time? And so there are some people who are, having these symptom relapses and wondering, oh, did I just get infected again? So unfortunately, obviously I can't diagnose this. I shouldn't diagnose anyone. I'm not a doctor. And I'm not sure about this specific case, but yeah, that seems to be the working definition.
Yeah, thank you. And then we have a question. We're seeing racial disparities in who's getting and dying from the coronavirus. Are we also seeing that in terms of who's getting long-term symptoms, or is that still totally unknown?
I don't know if Fiona knows anything. I'm not sure that has been studied so far. And again, some of it will depend on how we sample, sample patients and follow them. Like if we have unless we do it rigorously, I think if we, I worry that we will end up missing patients unless we do it prospectively and unless we follow patients and have a system. I do feel that we are at risk of missing patients who may be marginalized to begin with.
Yeah, I would second that. I don't know of any data on it. And I think it's just very important to remember that we're probably missing a lot of data on long haulers in general. As David mentioned, we need a tracking system or a database. A lot of these patients, the ones who do manage to test positive, eventually test negative and then are often, considered by their state to have recovered, which means they're no longer seen as patients. They're no longer in the system as people who are experiencing symptoms. And I think we can all agree that, due to systemic racism and the issues that we've been talking about with medical bias, it is more likely that people who are coming from communities of color or women or some of these other groups are going to fall through the cracks perhaps more easily than others.
We have a question from Cassie Chu who asks, do long haulers have the potential to spread coronavirus past the current 10 to 14 day isolation period?
We have no evidence of that so far, and so I think that one's very simple. I don't think that having long haul symptoms has anything to do with infectivity of the virus. So I don't think that that's so far. I wouldn't say that that's related.
That being said, I do think it's an interesting question because some public health guidelines are still not really accounting for long haul COVID, and so public health guidelines that say, to wait a certain amount of days after your fever has broken, for example, are very confusing to long haul patients who sometimes have a fever for, 3 months. So it's a good question. And it's one that comes up a lot in these groups. But I think the doctor is correct in the fact that there's no evidence to show.
We have a question from Stephanie Sutherland. Is there any research connecting post-COVID syndrome symptoms and presentation with chronic fatigue syndrome symptoms or other chronic pain conditions, for example, in terms of mechanisms, inflammatory or immune mechanisms?
We know that inflammation is, for a lot of chronic pain syndromes, inflammation is really one of the central mechanisms, but I'm not sure that this specific question has been well studied. I don't know if anyone else knows, but I'm not aware of any research so far.
So the definitions for ME or chronic fatigue syndrome, not all, but they've historically been 6 months out. You sort of see if someone meets the definitions. And there are a number of definitions, and that's a big controversy, what definition, but we don't really know, partly because, again, we don't know, there's not been good research on ME. If we knew more about what caused ME after a viral infection, we might know more, are some post-COVID patients going to have ME? Undoubtedly, some will meet the definitions for ME, and the core definition for ME has been not just fatigue, fatigue is a misnomer. It's this kind of profound collapse or relapse after, as Fiona suggested, some patients have for post-COVID, minimal exertion, minimal mental or physical exertion, and you have a completely disproportionate relapse and profound sort of paralytic kind of exhaustion after that. And so it's not clear to me, it sounds like some post-COVID patients, so that's the classic, cardinal ME symptom, and then there's other required symptoms depending upon the definition. It's not clear to me that the fatigue, some people with post-COVID seem to report that kind of relapse, others seem to just report bouts of exhaustive fatigue that seem unrelated to anything in particular. So I don't think it's clear yet how many or what percentage will be diagnosed with ME, depending upon the definition. Many will have other post-COVID syndromes that are unrelated probably to some of the kinds of symptoms that ME patients have.
Dr. Arch, did you want to add anything before we go on to the next question?
No.
We actually have a question for you, David. Dr. Tuller says journalists have erred in taking the predominant medical view on chronic fatigue. Whose view would he prefer we take? By his own admission, some patients misreport, and anecdotal evidence is always problematic for a variety of reasons.
Okay, so this is a very challenging problem. I have a public health degree, which means I know about epidemiology. And so if you know nothing about research and studies, it's very, very difficult. I understand. Of course, we take the Lancet or New England Journal of Medicine, and we have something's published and peer reviewed. And I was, grew up, or, when I was doing journalism, if it's peer reviewed, you can sort of assume it's good. We've seen now that that's in fact not the case. Often things aren't good, and sometimes those problems can be obvious, and sometimes they're really, really difficult. And I'm not a statistician, so if it's a statistical issue, it can be hard, to look at. I would just say that don't take it for granted anymore, that just because something is published by a high-profile researcher or in a high-profile journal, that it automatically means it's absolutely true. It may be, and it may not. And there's research misconduct, there's inadvertent, terrible, and unintentional mistakes. There's a lot of things going on, especially now in an environment where people are trying to get information out quickly for very understandable reasons. So all I would say is, at this point, as soon as research comes out and is published, if it's bad, there's immediately a controversy about it because someone smart online has picked it up. So I would say that, in general, just check out whether there is an ongoing controversy about the research that you're looking at. No one expects journalists to be statisticians, and no one expects them to get everything right. And I was looking at research in chronic fatigue syndrome for a year before I was able to figure out how the bad research in the UK was being done and to write a whole thing about it. So it does take a while, and it does help. I would say the most helpful thing for anybody, if you have the time, is to take an epidemiology course if you want to learn how to read studies.
And we have a question from Indrani Basu. And I know that we touched on this earlier, so you may, maybe if there's something additional either of you want to add, the two journalists, but what is the best way to get in touch with long haulers and interview them? Are there any tips or best practices while interviewing them that reporters should be aware of before asking them questions? And finally, and this is the more sensitive area, how do you fact check them? And she went on to say, how do you fact check testimony by long haulers, given that many marginalized communities might not have the traditional proof that Fiona referred to in her talk?
Yeah, this is a great question. So one thing I want to mention before moving on to the fact-checking question that I didn't mention in my earlier answer is, in addition to kind of all of the other aspects of sensitivity that we should be bringing to these interviews, language also matters, and a couple of kind of key words to just watch out for. A lot of patients, myself included, get asked in every interview, have you recovered yet? Or when did you recover? This idea of, kind of a black and white recovered or not recovered is I think, not the case for many patients. And it's a question that reasonably frustrates a lot of patients who are still in the process of recovery. So that's something I'd mention. Also want to mention that the words survivor and patient seem to be used interchangeably right now by a lot of journalists. COVID survivor, COVID patient. These mean two different things. A lot of people, a lot of long haulers do not consider themselves to be COVID survivors because they are still experiencing debilitating long-term issues. So I like to use the word COVID patient or person living with COVID, or to ask the interviewee how they identify. Another thing I wanted to mention is this idea of post-COVID syndrome. Long haulers are very divided on this term. Some really love it. Others are concerned that, they may have something that has already been diagnosed, like ME/CFS, and that, calling them a post-COVID syndrome person is going to mean that they're not going to get access, kind of the resources that already exist for those other conditions. So that's not, it's a dispute amongst patients as far as I've seen. It's just something to be aware of. Regarding fact checking, I think this is always good practice, but I think explaining what fact checking is really important when you're reaching out to a patient to fact check, especially given that a lot of these patients are very used to their stories being questioned and may interpret it as, a hostile move even when it's not one. So, that's the first thing. A lot of these patients don't have a ton of experience with journalists, so I think just explaining what fact checking is very important. But beyond that, I would question sort of how do we fact check? Are we looking at test results? Are we looking at medical documents? Are we trying to speak to doctors? I think reaching out to a patient's doctor, asking a patient to connect you with their doctor is not really the right way to go, because most of the time the doctor is going to be unwilling to share that information anyway, and even with the patient's consent. And then beyond that, this question of, positive, negative test result. A positive test result is also not proof that someone has COVID, right? There are also false positives. positive. So I think, anytime that we're talking about a COVID patient, it's important to talk about the accessibility and reliability issues with test results, regardless of whether they've tested positive or negative. And putting that context into the piece can also offer a bit of a caveat of, yeah, it's hard to diagnose COVID. And, this is the patient's experience. This is what they, say they were told by their doctor or maybe didn't get from their doctor. And this is the context for why it's that complicated.
Thank you. And with that, we're going to let Fiona be our closer here. I want to thank our three really wonderful panelists for their insights and our audience for their thoughtful questions. I know we couldn't get to every question, and we will try to see if some of those can be answered afterward. We have a feature on centerforhealthjournalism.org called You Asked, We Answered, and maybe we can tackle a few of them there. And that column is focused on COVID. And then the other thing I would mention is that we will be archiving this webinar at centerforhealthjournalism.org, and you should be getting an email about that as well. And that we will be sending you a survey shortly asking for your feedback on this webinar and your ideas on what you would like to see us cover in a future webinar. And finally, should you want to support this series, here's a simple way to do it. Just send a text to 41444. We depend on the support of foundations and individual supporters, and every bit counts. So I just want to thank everybody and wish everybody well.
Thanks
for having us.